So let's get rolling before I freeze again. So awesome. Thank you so much for everyone for joining us today at Northwestern's Geriatric Grand Rounds. It is my deepest pleasure that I get to introduce Dr. Mary Duggan. She is Associate Professor of Medicine in the Division of Geriatrics within the Department of Medicine at Vanderbilt University Medical Center. She is also a leader of their GREC. And she is a superstar, and I am like a giant fan of hers. So I am easily like flag waving that I'm so excited she has agreed to come talk to us. So without further ado, Dr. Duggan, I'll send it over to you to start talking.
Thanks, Lee. The feeling is mutual, and thanks for getting me through my geriatric boards. I actually watched your lectures from like the PASS machine, I think it was called.
That was years ago.
That was years ago. I loved your lectures. They were amazing. So I've been a fan of yours even since before we met. So it's great to be here with you all virtually at Northwestern. And I've been a big fan of Northwestern ever since I interviewed there for residency and met Diane Wayne. And then heard about her work more at Reynolds meeting and learned about her work and Dr. Bradley's work and Lee's work. And it's been really fun to kind of see all the cool stuff that y'all are doing. And so I'm really honored to be here with you guys today. We're a pretty small group, so feel free to shoot any questions in the chat. You can also just unmute yourself. I'd love to make this interactive, and I'll try to leave some time for questions at the end. And I'm really excited to share with you one of the silver linings of the COVID pandemic in geriatric education. And yeah, we'll go ahead and get started. I don't have any financial conflicts of interest to disclose today. So I'll share with you a story about the development and early outcomes of Geri-a-FLOAT, this national online learning community that we developed out of a need that we saw during the pandemic. By the end of our session, I hope you'll be able to discuss the impact that the pandemic has had in the training of geriatric medicine physicians and why developing effective geriatricians really matters so much in our world today. So if we go back to Friday, March the 13th, back in 2020, it was my first year being a program director at Vanderbilt for the Geriatric Medicine Fellowship. I had just found out, so I was a brand new program director, found out I was pregnant with my third child, and the WHO had just declared COVID-19 a pandemic. This actually was the exact day that in the US, COVID was declared a national emergency. So like many of us, I had a lot of worries personally, but also what to do with my fellows. One of my fellows was pregnant. I was worried about her safety and wellness. I was worried psychologically about the impact on my fellows. And I was, of course, worried as an educator about their learning. Clinics were closing down, nursing homes were shutting down, in-person conferences were canceled. How are we going to shift everything to online teaching? I was just feeling like really overwhelmed also while being pregnant with a third kid and trying to manage two young children. So, there were some available resources to support fellows, both from a learning standpoint and also sort of personal and wellness supporting the fellows. So Aquifer Geriatrics has some really great case-based learning for many specialties, including geriatrics, but Aquifer requires a substantial paid subscription, and much of the content is quite introductory and perhaps too basic for fellows, especially fellows later in March, towards the end of their year in fellowship. POGO-E, the portal of geriatrics online education, existed, but as you may know, it really requires a lot of sifting to go through some much outdated curricula that exists within that portal. The Most Difficult Case Conference is a great conference that programs will do across a time zone, but that really only occurs once a month, so may not be robust enough to help support geriatric medicine fellows. Project ECHO, GECs, and GWEPs, these are available in some areas, but not nationally, and locally, we really didn't have interactive video conferences through an ECHO or really a lot of robust educational resources that we could plug fellows into. So from a learning standpoint, there really wasn't a ton to lean on. And from a support standpoint, the American Geriatric Society definitely has the mentor match, which anecdotally we've heard a lot of fellows don't really participate in. And then the fellows in training group, which really just met once a year to support fellows at the AGS meeting, which of course was canceled. So, but this idea of using video conferences through something like Project Echo to pull programs resources and pull people together and train people from across the country during this really challenging time seemed like, maybe there was some merit there. And we knew from prior experience at the VA, so in particular, the VA Quality Scholars Program, they use video conferencing for sites that are geographically dispersed, and that curriculum was previously found to be feasible, result in learner satisfaction, improvement in knowledge, and some measures of transfer. We knew that sort of existed. And similarly, an academic VA partnership existed for educators, for educator development in geropsychologists in training that combined programs from across the country with a very small number of learners to sort of learn together. So there was sort of a precedent for this. And so a few of us connected and thought, well, let's try this out. The 5 people pictured here, none of us had ever met in person. None of us had ever worked together on a project, even remotely. But within 5 days, 4 days really, we had set up a joint journal club between these 5 fellowship programs. And it was followed by a group discussion to debrief about the pandemic and everything that was going on. And for us program directors and faculty, we were really grateful that we could rely on other programs' didactics to augment our fellows' learning. And our fellows really liked it and wanted more. And just by happenstance, we happened to connect. It was really via AdGap. I posted something on AdGap about doing a joint journal club, and the other 4 faculty pictured here had already connected on Twitter. And so I was looped in. And so it was really largely through Twitter that we were all connected. And what we heard after that first session was that fellows felt really isolated. Many were forced to stay home. They had their learning reduced. And so now looking back, we know that isolation, lack of community was really compounded by significant mental health concerns. So broadly among healthcare workers, psychological symptoms and distress affected up to 2 in 5 healthcare workers. And in residents, up to 1 in 5 had suicidal thoughts early in the pandemic. And this mental health impact was seen not only in the frontline workers in the COVID ICUs, but really in all healthcare workers, including non-frontline workers. And if we looked more specifically within geriatrics, you all, I'm sure, are very familiar that geriatrics was particularly affected, our patient population. So early in the pandemic, over 80% of deaths were in adults that were older. Nursing homes were tremendously affected, right? There were clinician and staff shortages as cases increased, and many were infected with COVID. And for many, their jobs as perhaps outpatient docs or home docs changed to phone calls and really just calling panels to provide advanced care planning. I mean, we saw also ageism just rampant within our society. And if we look more specifically within geriatric fellows, there was some literature that came out showing what we all were hearing anecdotally at the time was that didactics are canceled. They're being replaced by pandemic-related content. So they're not getting the geriatric content that they needed to be getting as geriatrics fellows. Clinical training opportunities dwindled as nursing homes closed doors to trainees and in-person clinic volumes downtrended. Fellows were shifted at some institutions into COVID-19 staffing pools. And most geriatric fellowship programs are small without much staffing reserve. And so staffing shortages could disproportionately affect geriatric fellowship programs when they occurred because someone contracted COVID. Additionally, national society conferences were canceled or they were transitioned virtually, impacting not only learning, but also networking opportunities. And at a personal kind of wellness level, fellows were increasingly experiencing burnout and isolation. And geriatrics fellowship is short, right? You only have 1 year to learn how to care for complex, vulnerable older adults and how to improve the health system for older people. So this was a huge negative impact. And so if we kind of just take a step back and just kind of reflect on what most of you already know, that the population's aging and we have a huge supply demand mismatch when it comes to geriatricians. And geriatricians aren't the only solution to this multifaceted challenge of our growing aging population, right? But geriatricians certainly have been influential in improving care for older adults. And so there's a huge demand for providers who specialize in geriatrics, as you see here in the orange bars, and just a really big mismatch. So speaking of match, it's been match week, right? We had match day a couple of days ago. And we know that historically about half of geriatric fellowship positions fill. And just this year, 2 days ago, only 43% of the positions filled. And that's the lowest we've had in at least over 5 years. And just to put that into context, this I saw yesterday on Twitter from Dr. Carmody that you really can't get any worse than poor geriatrics, right? I mean, our program fill rate is at 33%, which is the worst among all medicine and pediatric specialties. So you all should feel very fortunate to not be to be included in the 33% that actually filled and to have successfully matched a fellow. So kudos to you all, Northwestern, for having a great fellowship program there. So with this growing aging population, small number of geriatricians, the big demand, it's really important that as academic geriatricians, we recruit people into geriatrics, we train them adequately, and we really care for this really precious commodity that we have in our trainees. And this is really hard, right? Training geriatricians in 1 year to become super specialists, as John Morley at SLU calls us, is really tough. Geriatrics is this meta discipline. It transcends and informs all other medical disciplines. And not only do we have to be super specialists for individual patients, but we also have to know how to diagnose and treat health systems and do all of that in 1 year. So that's a lot. And in fact, geriatric fellowships in the 90s used to be 2-year programs, and were reduced to a 1-year program back around the mid-90s, partly as an attempt to recruit more people into the field. So training future geriatricians is tough, and then compounded on top of that, the pandemic makes it even harder. So how could an online learning collaborative potentially help with this challenge? And we suspected that it could early in the pandemic. So we decided to give it a shot with this online learning collaborative. We brainstormed potential acronyms because every worthwhile initiative, of course, really needs a good acronym. And since we focused on fellows learning online across the country, we considered felon, but ultimately we went with Geri-a-FLOAT, which seemed a little more positive. So we set our mission to be number 1, to deepen knowledge of geriatric medicine, and number 2, to bring fellows together across the country for both networking and peer support. This was intended to serve as an added layer of education and peer support during challenging pandemic times. And we really like that float concept, the idea that we were keeping each other afloat during a really stormy time. And really, it also reminded us that a rising tide lifts all ships and that we're better together. And so that's what kind of kicked us off as we started out. We mapped out an efficient process that would allow for weekly meetings on Zoom with fellows and faculty signing up to present topics through a Google spreadsheet. We weren't very advanced. This was an unfunded effort. So we just sort of crowdsourced resources and developed an evaluation survey to assess learners' satisfaction with sessions and for ongoing quality improvement to get feedback to iteratively improve the sessions over time. So the first 5 sessions included fellows and faculty from 14 institutions across the South, Northeast, Midwest, and Pacific Northwest that are pictured here. We published the evaluation of our first 5 sessions in JAGS in the Geri Corner segment. We had 56 participants in these first 5 sessions, and overall sessions were found to be well received. We were a bit surprised that we found such a high rate of intent to change, with 100% of the respondents indicating that they intended to change either a professional or a personal practice because of a Geri-a-FLOAT session. And while intent to change isn't an objective long-term behavioral outcome, it has been associated with future behavioral change in the literature. And so we were really encouraged by that we were maybe making an impact. And we continued on. We asked learners what was most helpful about Geri-a-FLOAT. And we were hearing 3 big themes. So one, the